see different leadership that we have. We've got Richard Maxwell, who is the vice chair. We have Susan, who is our secretary. We have Taylor, who is our PR and technical guru. We've got Ambrose Cobb, who is taking a new position, which we'll talk about in a second. And then we have Johnny Cartwright, who is also taking a new position, which we'll discuss in a second. So our agenda, if you all saw it when you walked in and signed in, we're going to go through some of our Veterans Mental Health Council business first, and then we'll get to our panelists. We really appreciate you all attending and teaching us more about PTSD, substance abuse, and suicide prevention. All right, so first things first, we have a new task force. If you recall, last month we had a meeting on the incarcerated veterans issues that had come to our attention. That was a really passionate discussion, and we learned a lot about services that are being denied or not accessible to our veterans who are in prison. So it was an extremely interesting topic. We have, since that meeting, we've actually attended a veterans fair at one of the prisons in the state prison system. That was extremely interesting as well. That was extremely interesting as well, so I can share a little bit about that, but all the information will be put online. So we went to Esther Unit. Esther Unit is in Pine Bluff, and Esther Unit has a brand new veterans program. And so what's really interesting is that they've already set up a wing just for veterans. It's got 46 beds. They have their own rec yard. They have their own leadership council. Great setup. It's brand new, and we're going to work with them and kind of develop a program. So I'll talk a little bit about that. But because of that meeting, we realized that we need to do a little bit more. We need to step up and help out our incarcerated veterans. So Ambrose, if you could, well, not that you need to stand up because your picture's right there, but Ambrose has volunteered wonderfully to lead that task force in learning how we can better help our veterans. So stage one of that is going to be that he's going to work with the Esther Prisons Veterans Unit. Since it's already established, that'll be a great place for us to learn and kind of learn how to implement a program and then maybe take that to other prisons. So he's going to create a resource, or he's not. He's going to lead the task force that's going to do this. So he's going to create a resource binder and train the Veterans Council members. They have their own leadership. Remember I said that? They have like a 7 or 9-man team. I don't know if anybody remembers who was there. But they already have an established leadership presence. And he's going to arrange for them to be trained to kind of act as advocates for those veterans who are in prison. They'll be able to help each other do their benefits, get eligible, find out about, okay, when it's time for release, where do I go, what do I do, what paperwork do I need to do, take care of, all that kind of stuff. So he's going to start that. Then he's going to appoint one of the people in that Veterans Council. Our hope is that that person will be somebody that's got a longer sentence so that they can be like a permanent liaison between that prison's group of veterans and our Veterans Mental Health Council. So he's going to get that started for us. Then he's going to create a process to track veterans from their intake. Apparently all the veterans, or not just veterans, all the incarcerated people that go through the system, they're all taken to one place for an intake brief or meeting, or what you call it, like an interview, I guess. And at that point, they're identified as whether they're a veteran or not. So we want to work with the Department of Corrections, get a copy of the list of all those people that are the veterans, and then track them through the system so that we can, at the beginning, maybe give them one pamphlet. Here's what you need to do while you're here. And then maybe 6 months before they're about to be released, here's what you need to do now that you're about to be released. Here's who your advocate is in your prison. That kind of thing. Let them know a little bit about who we are. So we want to track them and provide them information through their process in the state system, prison system. Then we're going to collaborate with the Arkansas Department of Corrections and the VA hospital on the possibility of providing services. We talked in the last meeting, and I won't go into too much detail, but there are laws that intergovernmental contract of services. So if that comes to fruition, then we'll explore that. If that doesn't, then we may need to explore changing the law or creating some of the policies or guidelines, whatever. But we want to make sure that those veterans are getting services. And Dr. Koo has been amazing. He's been leading a team that is working on, with the Department of Corrections, the director of the Department of Corrections, on trying to work together to make this happen. So that's wonderful, wonderful news. But none of it's happened yet. It's all in the kind of discovery phases. Then stage 2, eventually, once we've mastered stage 1, then we'll move on to trying to recreate this program regionally, so that we have a same kind of veterans unit, maybe in different areas of the state, so that we could eventually get all of our veterans in a veterans wing that has all the resources that they need. So that's our goal. And then stage 2 also will be the evaluation and analyzing state laws, procedures, policies to see, and possibly even national, to see what needs to be changed so that our veterans are receiving services. All right, sorry, that took so long. Okay, on the bottom of the appointment letters that you get, if you have a veterans mental health appointment, there's a long letter that you get in the mail, and it tells you about when your appointment is. Dr. White has been working wonderfully. This is something Taylor started from a long time ago, and we're just following up on, but Dr. White has been working with the VA hospital, and we're about halfway through that permission.
It's waiting on the facility leadership to give the okay, basically.
Yeah. So we've gotten some okays in the middle management areas, and we're just waiting for the very top. So that, if it's approved,
Flood warning.
okay. Not good, but better than a tornado warning. So that appointment letter, little blurb, would be at the bottom of that appointment letter, and it would say that the Veterans Mental Health Council is an independent organization run by veterans dedicated to improving our mental health care system. To provide feedback about your appointment and services, learn more about what we do, find out about our next meeting, or get involved, you can go to, and it's going to give the website, our new email address, and the phone number. So in preparation for that, we had to have a website, an email address, a phone number, and we figured we better have a logo. So this is what we've come up with. The Arkansas Suicide Prevention Network already has an existing website. We are tapping into that and just having pages on that, but we will have our own domain name, so you can get there one of 2 different ways. And then we have an email address, you can see that there, and we have a phone number. At this time, until our leadership decides otherwise, that phone number will go to a voicemail. That voicemail is then transcribed to an email that all of us will receive, all of us in leadership will receive. That way, we instantaneously all get the same message. We can figure out who needs to respond to it, and we can respond to it appropriately. And then that way, if one of us isn't able to answer the phone, that's not an issue, because there'll be 4 or 5 other people that can respond to that veteran. It does say on the website pages that we are not in any type of capacity to handle crisis, and it will make sure that they understand that if they're in crisis, they call the hotline. But this is just to ask questions about the Veterans Mental Health Council. So we'll make sure that's clarified. All right. The next thing that we have as far as Veterans Mental Health Council business, we have a new program. Johnny, if you could stand up for everybody. We are creating a Veterans Outreach Program. He disappeared. He decided to go hide. Johnny is going to man that up. I really appreciate him taking that on. That's something that as leadership we've wanted to create for a long time, and we needed a really strong leader for that, and so Johnny has stepped up. That program will probably start June, sometimes towards the end of June.
First week, second week of June is when I'll start going in. I'll go into the outpatient patients, and I'll have appointments and start talking.
And so that's what we've got up on here, is that he's going to go into the VA hospital. We've gotten permission from the VA's mental health unit, and Johnny's going to be able to go into the inpatient and outpatient programs and have discussion with them, let them know what we are, what we do, invite them to come to our meetings. If they don't want to come to our meetings, but they want to give us feedback, that's what he's going to work on. And then also outside of the VA hospital, he's going to do some networking and going to different meetings and informing the public of what we do, who we are, and how we can help veterans, and inviting people to our meetings, and trying to get feedback. If people don't want to come to our meetings, we still need their feedback. So that's something he's going to work on. And then he will let us all know, and there'll be like a PSA on Facebook that will advertise when he starts having those meetings. The veterans outreach meetings will be totally different than these meetings here. The veteran outreach meeting will be a very casual meeting for veterans only, where they can voice concerns, where they can speak freely, where they can ask questions about services, or if they need help with something, if they heard about something in this meeting that they had even more questions about, or didn't agree with, or anything like that. That's going to be their outlet there. That's for veterans to reach out to each other, to support each other, and for us to get really honest feedback from our veterans on what they need. So, did you want to add anything?
Yeah, one of the things is me have gone through these programs and the PTSD and I've been through the SUDS. Someone had to take me by the hand like a 3-year-old and show me these programs and basically do a shakeover with me, with the people in these programs for me to be able to go through this. If it wouldn't have been for me having someone do that with me, I would have never got as far as I have with managing my PTSD. That's why it's so important for me, for us to outreach. There's a lot of veterans out there that pull up in this parking lot every day that don't go in. Because they don't, the truth is they're grown adults, but they're still have teenage minds. A lot of us do. It's going to take people like us getting out there and saying, hey, let's go get the help we need. That's where I fall in, and that's where my passion is at.
Thank you.
The one that helped you, was this a staff member or a fellow veteran?
It was a staff member from one of the other, the backside. But they took me and said, hey, just so you go meet, and they didn't say, that my pet peeve, and I'll walk around these halls, is to see someone lost, see someone walk by, or say, hey, where do you need to go? Well, I'm looking for so-and-so, and they say, well, it's down the hall, it's around the corner. That bed is not going to make it there. And if they do, it's going to be 2 hours later. They're going to be mad. The employee wondering why they're cussing. And then, they just don't get it's not a good chain. It's just not a good chain. There's a better way.
It's got to happen a lot. It's a rare week that goes by that I don't have at least 1 or 2 veterans or family members in the hall that wind up helping, directing. It happens all the time.
And it's not that. It's just that a lot of them don't know exactly what all is out there and the things that are offered to them. It's just because they don't know and they haven't been properly introduced to it. Thank you.
Thank you, Johnny, for taking that on. And he will eventually form a committee of people that he will work with to help do exactly what he's talking about. So if that's something you're interested in, then send an email to our new email address. All right. From now on, because we are going to have a veterans outreach meeting, that will be a place for veterans to discuss things very openly. They can have their gripes there, they can ask really tough questions, that kind of thing. This meeting is going to become the education meeting. So this meeting will be for the purpose of educating veterans, for educating our providers, our stakeholders, and any guests that come in. And because of that, we want to make sure that our guests and our speakers feel really comfortable in sharing their information, and we want to make that a very welcoming environment. So we want to allow our presenters to speak without criticism or fear of judgment. We want to allow the audience to ask questions for further understanding. We also must provide a venue for those who are unable to attend. And we repeatedly get questions from people around the state asking if we can come to like Fayetteville or Jonesboro or wherever. Well, we're the Central Arkansas Veterans Mental Health Council. but apparently they are craving the information that we're providing. So this is a way that even if they lived in another part of the state, they can still hear the information that we're sharing, because it would be inappropriate for us to go to Fayetteville or those other locations because that's not our area, it's not our jurisdiction. We are the Central Arkansas Mental Health Veterans Council, or Veterans Mental Health Council. It took me forever to say that. Okay, so we are establishing procedures for this meeting. So from here on out, meetings will be held, they've always been held, but on the first Wednesday of each month from 3 to 5. We are keeping that meeting at that time because most of the people that come are providers, professionals, and we do have some veterans, but it's mostly stakeholders in the community. So we want that time to be during work hours so that everybody can come on their work time. The Veterans Outreach meeting, however, will be at a time where people who might work at a civilian job and aren't able to come, or don't work, or maybe they are in an inpatient program and need to be able to come to a meeting, but they can't come to this time. So those meetings will be at a different time so that to provide flexibility for those people so that they can attend the meetings. Meeting reminders with information about the topic and speakers will be advertised via email and social media at least 1 week prior to the meeting. Meetings and speakers are planned out at least 1 month in advance. So, if you would like to be a speaker on a topic or you have an announcement of any kind, feel free to email us. And if it's appropriate for that meeting's discussion, we'll make sure that announcement gets made or that person is invited to be a speaker. If it's not appropriate for that meeting, then we will try to schedule it for another time, another meeting. Questions for speakers and guests from now on. Because of some feedback that we've received, from now on, all questions will be, you'll see some paper in the middle and some pens. All questions, we ask that you write them down and then give them to Richard right there. And Richard will read those questions to the panel members, and then you will get your response that way. Okay? That's out of respect to the presenters. We have had some complaints from some presenters, and so we feel the need to do that from this point forward. Meeting agendas, handouts, and the recording that we have, and the PowerPoint slides will all be up online within 1 week of that meeting date. And a link or an announcement will be sent out on social media and on email that is up and there for you to view. So if you're not able to make a meeting, then you can just go to the website and you can find the meeting there. Last month's meeting is already up online. If you wanted to go and check that out, please don't use our website yet because they're not connected. So if you want to go find that one, let me know and I can send you the link, or you can go to the ArkansasSuicidePrevention.org website and view it that way. All right, I apologize, which is a lot of announcements that we needed to make, and we are going to move on to our panel. So what we're going to do first is we're going to introduce each panel member and give them an opportunity to speak a little bit about their program and why they're here and what they are going to discuss. And if they have any slides, we only have one person give slides, but if we have slides, they will go through the slides. The rest of them provided handouts for you at that table. If you didn't get them, feel free to go over there and get them. So we will start with Dr. Rita.
Thanks for coming out. It's always good to be able to talk about the issues we're going to address today. And we're going to deal with some of the most common and, quite frankly, the most damaging issues that veterans face: PTSD, substance use, and suicidal behaviors and suicide in general. It's always good to talk about PTSD because I believe it's a widely talked about but poorly understood disorder. And so hopefully through further education we can do a better job of getting the word out about this evolving disorder that is still very new. We only had it as listed as a diagnosis back in 1980. So as disorders go, it's still very new. And like I said, I think it's pretty widely misunderstood, even for people who suffer from it. It can manifest itself in a lot of ways. It can look like other things. It can be politicized, as we know. It has many different opinions that come of it. So when we're talking about PTSD, If you do a overall epidemic kind of poll, Americans, and you look at their health and their health care, we estimate that anywhere between 7 and 8%, so a pretty consistent number, but 7 to 8% of Americans are diagnosed with PTSD or some other trauma-related disorder over the course of their lifetime. When you think about trauma, in the general idea of trauma and what it is and how many people are exposed to it, it's actually good news. What I mean by that is it's estimated that about 60% of all males in America experience a trauma over the course of their lifetime. That's military and civilian. 50% of all females experience some type of trauma. So we're obviously not just talking about combat trauma here. So the good news is, well, one piece of news is trauma is really common. Lots of things can happen. The world can be a dangerous place. And for a lot of us, we experience these things. The good news is much less people develop PTSD than that. So most people are able to experience an event and not have it impact their life in a way. Where the game seems to change is when we get repeated traumas involved and other things like that. So one age-old question is, who develops PTSD? Why do we have Jimmy and Joe and Bill sitting in a foxhole, and Jimmy and Joe came home from Vietnam and they did fine, but what's wrong with Bill? And we started looking at that in our field. And quite frankly, our answers still aren't very satisfying of who gets PTSD and who doesn't. We've got a couple of factors that we look at that help us more or less try to answer that question. One factor is very obvious, the severity of the trauma itself. So if a veteran or somebody goes off, fights a war in service to this country, and they put themselves in harm's way a lot, or they find themselves in harm's way a lot, very dangerous events over and over again, and these aren't uncommon experiences to the deployed soldier, their chances of getting PTSD are pretty doggone good, because they're getting exposed to a lot of really dangerous events. So that makes sense. That makes sense, and we can understand why that person might be at a higher risk to get PTSD. Another factor that we look at quite a bit is what we would just call risk factors, and that's a general, very uninformative heading, and what we basically mean by that is anything that would make your life more difficult would definitely contribute to the likelihood of you developing PTSD. So if we think about those things, that could literally be almost anything, ranging from homelessness, financial problems, childhood history of trauma. We know more than ever that a lot of our veterans' first experience with trauma did not occur in the military. It may have occurred well before in many cases. A lot of people join the military to get away from something. We've heard those stories. So that's another big factor, is what kind of risk factors are we looking at with the individual, either before or after they've experienced the trauma in terms of how they develop PTSD. So those are some numbers, but numbers really aren't that important when we're talking about this stuff. What is important is the impact of trauma, the impact of PTSD. We see it all over the place, but PTSD literally crawls into every area of your life. There are 20 recognized symptoms of PTSD right now based on the most recent diagnostic classification, and if you look at those, and I encourage you to look at those, having almost any one of those symptoms would be very difficult. And my patients often have, at a severe level, more than 10 of those symptoms, anywhere from 10 to all 20. So this is certainly a disorder that impacts and has the potential to impact every area of your life. And as we put it, it will take everything you give it. So I think the primary impact of PTSD, the more and more I look at it, is in the belief system. I think the first thing people notice about PTSD when they get it is how it makes you feel. And that's pretty obvious. It's hard to ignore. You don't sleep very well. You anger quicker. You get more anxious and fearful in a variety of situations and things like that. Well, all that kind of stuff is very difficult, almost impossible to ignore. But what really flies under the radar and truly provides a lot of the impact and the damage of this disorder is its influence on the belief system. And in working with PTSD for a while now, it's been my experience that when you work with somebody with PTSD, they have some version of one, if not all three, of the beliefs I'm about to throw out there. So PTSD does have an impact on how we see the world and the belief system, we'll call it that. So belief number one has to do with the world. And so a very common or typical belief would be that the world is a very dangerous place. And we can certainly see where this comes from if you've been deployed to dangerous places in the world, or if you've had things happen to you in this world that have threatened your life, threatened your personhood, and things like that. It's certainly easy to see how this belief would come about. Certainly our men and women in the armed forces have seen some of the worst that the world has to offer, some of the most dangerous places you can possibly go. So that belief, we understand that. That makes a good bit of sense. Second belief, or another belief, would be regarding other people. In other words, the kind of the message is don't trust people. They can be very dangerous. And again, certainly if you've been in combat or if you've been a victim of abuse, neglect, things like that, more civilian-based traumas, you can certainly see where that belief comes from. People are capable of some pretty horrible things. Thankfully, most of them aren't, but some are. And so it becomes easier to just kind of generalize over time that all people are potentially very dangerous and we should keep them at bay. You can very quickly see how this kind of belief system might impact somebody in a healthcare setting. And we'll get to that in just a second. The third belief makes all the others take a back seat. The third belief is about the person that's affected themselves. And so that belief can manifest itself in something like, I'm broken because this happened, I'm worthless because this happened, I'm weak because this happened, I'm not worth fixing, I'm unlovable, whatever. But the impact on the person's view of self is tremendously impactful. I had a very bright young man I was working with here a couple of years ago asked me a question one time. He's like, why did I get PTSD? And these other guys I served with did. Well, the first thing I had to answer for him is there's a damn good chance a lot of the guys you did serve with did get it. You just don't know yet. But once we got past that, I really struggled with the answer. But it was a great question. And the answer I gave him ended up being okay. I was satisfied with it. I hope he was. And that answer was, what's the difference between somebody that develops PTSD after deployment and somebody that doesn't? To me, the quickest thing I could look for that would really give me that answer would be, for the person that develops PTSD, those events became about them. It wasn't just an event that they could put on a shelf and say, oh yeah, I lived through that. Something about those events reflected in them and how they see themselves. And that seems to be the biggest difference I see between people who have deployed and for some reason have escaped that monster, or they deployed and they did develop PTSD over time, is that they have internalized this. It becomes a part of how they see themselves. So let's go back to those beliefs really quick. If you talk about, the world's a dangerous place, other people are kind of not to be trusted, and I'm worthless, weak, whatever we want to call it. The best analogy I can give you is if let's say, for example, we were going to go out and try to coach a Little League baseball team today. Whether or not you knew anything about baseball, if we were trying to do right by these kids and trying to help them out, we want the messages that they hear to be very clear. And so the messages we would want them to hear is, the game will be fair. In other words, you have a chance to win. If you abide by the rules, you have a chance to win. We got a good umpire out there. Another message we might want them to hear is, we got your back. We support you. We want you to win. We'll cheer for you. We'll be there for you. It's a great message to send people. I'm here for you. The third message we want them to hear loud and clear is, you're good enough to win. You can do this. You got this. So that'd be a great pep talk, right? Well, unfortunately,